we don't get an agreement into definitions, imagine, go and diving more into the unknown, that it's the management, and there's almost nothing. But well, that's the exercise of the ELAACC, and I think that it's going to be a good discussion. So we already know about the incidence, the prevalence of the viral-related thrombosis. So between, I would say, 1, 2, and even like up to 13 in some series with a lot of imaging surveillance. But this is, like I would say like an actual problem. So I mean, it's not, something that we don't see. We all see this type of complication. And we already know, I mean, this is like super known, this slide, that it has clinical relevance. So I mean, this is something that's prevalent and has clinical prevalence. So then we have to, manage, detect it, define it. So there's need for more research on this field. So here, I try just to collect all the publications on the determinants of DRT, because at the end, not only for detection, but also for management, if we have a lot of these factors, at the end, the risk of recurrence, it's going to be higher. So from the patient characteristic, we have old age, LV dysfunction, prior stroke, or even prior thrombus inside the appendage, permanent AF, chronic kidney disease, hypercoagulability, like cancer in all these states, vascular disease, or having, like a previous venous thrombosis. There's also factors related to the anatomy and the device implant, so like large LAAs, spontaneous echo contrast in the LAA, but also in the left atrium. So if you go deep, if you don't cover the ridge with, like a disc and lobe device, of course, if you have history of distal or, LAA thrombus, the presence of peri-device leak, like more controversial, but it seems that it's also related, and the presence of iatrogenic pericardial effusion. And at the end, we have like something to compensate. That it's what we're gonna choose to compensate all these factors that also need to live with the hemorrhagic risk, because most of the patients that we treat are high bleeders. So we need to compensate, like the intensity, but also the safety of these antithrombotic strategies. So, and at the end, what's modifiable? Because, from the patient characteristic, we can study them, we can know them, but like there's nothing to change. So we can change, the position of the device, also, the presence of leaks, no leaks, of course, the presence of iatrogenic pericardial effusion, and at the end, the strategy that we're going to choose for this specific treatment. So we already, discuss about the DRT definition. So at the end, there is a consensus, but it's not so clear as we've seen. It seems that, with this HAT grade 1, this very thin layer, so probably the risk it's kind of low. And also we have like this grade 2, that it's like a higher or like a larger thickness, a regular surface. So probably it's a DRT, and then we have the pedunculated, that it's clear that the DRT is there. So how we manage that? The other thing is that what we said, the antithrombotic treatment. So this is a very interesting publication in 2021, that you can check or see the antithrombotic treatments at different stages. So on the left side, anticoagulation at discharge of patients with DRT. So here you can see that most of the patients were on, red or green, means that antiplatelet agents, like or SAP or DAP. So DRT are highly associated with these strategies, so this is relevant. The other thing is anticoagulation at detection, so more or less the same. So likely more of the DRTs are detected while the patients are on DAPT or SAPT. And on the right side, the third column, it's how you treat, like in general, how we treat these patients. So blue, or like this blue, it's no therapy. So this kind of green-blue, it's heparin. Then we have like on yellow, vitamin K antagonist, and on orange, it's DOAC. So most of the patients are treated with anticoagulants, either DOAC, either Coumadin, or either heparin. And these are effective strategies. So here we have like our small series, from 2021. So it means that before that. So that's our series of patients treated with low dose apixaban. So we were actually really, surprised that low-dose apixaban was successful on treating these patients. Why we choose low-dose apixaban? Because those patients were at high risk of bleeding. So we were concerned of giving full dose of apixaban, and that's probably the rationale why we run the ADALA trial. That it's comparing that versus low dose apixaban after LAA, because what we thought it's that if low-dose apixaban it's good for treating DRTs, it's going to be even better for preventing them. So that's the rationale of the ADALA. But it's working for us, the low-dose apixaban for treating DRTs. And there's also a publication from Lluís Esmarat from Sant Pau that also Nina show that shows that the recurrence, it's a kind of an old publication, 2021, that DRT recurrence, once you have it, it's high. It's up to 35%. Here on the left, down, so you can see that the recurrence, it's 35. And the treatment of these patients that recur with the DRTs? So here you can see, the antithrombotic strategies. So most of the patients that recur are because or they're not treated or they are on SAP. On the other side, we have the patients that do not recur, so are the ones, half of them, or 40% with SAP, but also, a high rate of patients under anticoagulation. So here it's going to be like, one of the points of discussion. So what we need to do we need to keep these patients on anticoagulation? I mean, either full dose, half dose, whatever, or we should try, to stop and then see what happens. That's, probably, a very, a burning question. And this is also, the proposal of Casper and Janserik group on this very nice, I would say, paper describing all this, grade 2, grade 1. So at the end, what they say is that if you have a grade 3, that it's a pedunculated, like a clear DRT, so treatment should be considered. And they propose 4 weeks of treatment. That's also something that we can discuss here. Probably Lorenz and me later we can discuss that. And also the relevant question is for how long we need to survive. So once it's solved, for how long we need to repeat the surveillance? Do we need to do one more or just 2 or 3 until it's solved? So, I mean, there are like a lot of burning questions. And here you can follow, the algorithm if you have a grade 2. So possible DRT, again, probably the recommendation it's the same. I think that's something, Lorenz, that we can discuss later because there's like a lack of evidence on this field. And just to put more, I would say, confusion, on the session, I will show you different cases that actually highlight that DRTs behave completely different, one between the other, even with similar treatments. So this first case, it's a patient that after 3 months of DAP, I mean, looks okay. So maybe there's that, like grade 1. I don't know, like Janserik, if that's grade 1 or I don't know, like it's something that doesn't result like really scary. So it could look like something that it's a healing process, but then, so since we didn't have that data at that time, we just repeat this, this echo, and after 3 months more, so it means 6 months after LA occlusion, so then the patient develops clear DRT on this area, on this, under the pulmonary ridge. What we did? So we keep it. I mean, this is the same, time frame, and then we apply our strategy that it's apixaban 2.5, twice a day. So then we clean it, and since our patients are mostly, bleeders, so we don't like to leave them on apixaban. So we repeat it 3 months after, switching to SAP that it's going to be indefinite. So. And after these 3 months, it's clean. So should we repeat that, or it's enough 3 months? So that's a question. But at least, after 3 months, so it's clear. I don't know. Case 2, another one. Like after 3 months of that, you already see something that it's bad here. And actually, it's interesting because you can see that the ridge is not covered, and the initial, thrombus, it's placed on that triangle. But then, this was a very high, a patient with a high bleeding risk, so we decided just to keep him on that. So already, one day on that, you can see here just myxoma. It's not a myxoma, it's the progression of that thrombus. So here, everybody would say, like, that was the pin, because that was an ACP, that was not an amulet, that was the pin. No. Probably, like just the unsuccessful or the turbulent generated under the ridge generate this prothrombotic environment, and it's true. It, like just link, or it got trapped into the pin, into the screw. But the origin of the thrombus was up here. And then, we treat this patient, you can see here, very scary. We treat this patient with apixaban, no clinical events, luckily, because we were really scared. So we made it, 1 month and 2 weeks later, 6 weeks later, and then progressively with apixaban, the thrombus, got clean. And then you get this, part that it's under the ridge, kind of, like naturally covered with, like a tapering that it's probably this is good. So another example that maybe, like a thrombus that seems originated in the central part of the disc, it's not. Case 3. This is again an ACP, like from the early days. So we didn't care by that time too much about the position. We care about, stability, that we don't get an embolization. So I would say that this is a very suboptimal implant because honestly, like I think that, currently we would, try to cover the ridge and not leave this triangle, this, like pouch that I don't like it. But, as expected, the patient developed, after 3 months, a thrombus on that area. So we gave apixaban and we clean it. Again, a patient with high bleeding risk, so we stop it. So SAPT again, again. So we give apixaban again. But, like a patient had a bleeding, a GI bleeding, so we just gave, a final opportunity, and it came again. So again, to apixaban. And again, another bleeding event, because the patients bleed, on apixaban, and it's like, well, I keep it on apixaban, yeah, but the patient is bleeding, so what do we do? So finally, after 3 months after SAPT, we, after this second bleeding event, we checked that, there was no thrombus anymore on that area, and we try to get more information. That's another of the messages that I want to provide. And here you can see that naturally, that triangle was covered by, like a plain, like a flat thrombus, and that's probably the reason why it didn't recur. So this patient, it's on SAPT, and he has not presented any event. And let me show you sorry, this is case 4, the last case. And I'm gonna share with you, the medical history because it's a normal patient, 82, Church-Bascov 3, but, like with a scary and a big, thalamic hematoma with edoxaban, with half dose of DOAC. And the only thing, I would say, factor for a DRT was spontaneous echocontrast in the LA. So this is the anatomy. The anatomy, you can see that there's this spontaneous echocontrast here. It's an open appendage, with a ridge that you cannot cover, but I would say that it's not so bad because it's open. So here probably if you go with a disc or with a Watchman or with an amulet, you can get, probably a flat surface. So the ostium was really big and the landing area was small. So in that case, we thought that maybe in that case, alambre with a special scythe with 22 lobe and 34, disc would be good. And I think that the final result was not bad, but the ridge was not covered. So 3 months later, huge thrombus. So after that, so it's really scary. But the only thing that it's not, I would say that it's not empedunculated. So it seems that all the surface it's in touch. So, well, like I don't know if it can fly or not, but we just apply our, therapy that it's apixaban half dose, and we repeat. That's the same image. We repeat after 1 month because we were very scared. We didn't wait more than that. And here you can see that clearly, this DRT, it's improving. So again, you can check that the device, it's not so bad position. I mean, it's covering the ostium. It's not like generating any bad angulation. So we keep, the patient on apixaban, 2.5 by 12, and then you get this, like flat, I would say, not scary surface. And remembering the other patient, the last patient that I show you, so we believe, let's make a try, with aspirin, because maybe, that area that was scary, maybe it's gonna protect for future DRTs. So we switched to aspirin. And 3 months, after switching to aspirin, so CT, look, and like maybe the appendage, it's not patent because there's the thrombus, that actually doesn't let the contrast go in. So I don't know if it's because of that. So again, we switch into to apixaban, and after 3 months we repeat the CT. Look, again, like this thin layer, over the disc, covering, like, I would say, like benign, and again, it was like a intracranial hemorrhage. Again, we remember, like the case that I show you. So we gave another opportunity to the patient. Let's go back to aspirin. Look, 6 months again. Second, so we switched to apixaban again. Clean again. So, I mean, what to do now? I mean, this is like an amplified image. So what we do? I mean, it's a patient with a high risk of bleeding, 82. You're not going to send the patient to surgery because high risk. I mean, the bleeding, it was intracranial. It's kind of scary. So what we do? I mean, need to focus on modifiable factors. I mean, in this case, it was not really important. But probably, and Jordi showed this morning, maybe in these cases of recurrent, so we need to get more information. And maybe this functional information, it's going to tell us if we can just make this, downgrade of treatment, or we should better stay, with, like a more powerful tool or more powerful treatment. So my question, and it's like open to discussion, why DRTs behave so differently? Because, I mean, we have a classification, but as we saw, all of them behave completely different. One are benign, the others are not so much, and one, stop, the other ones keep on. So do we need in these cases additional information, meaning, like check for coagulation, check for functional information? Maybe it's the pulmonary veins that drain differently, I don't know. The other thing, what's going to be our imaging protocol surveillance for DRT? Should we wait 1.5 months, less, more, 3 months? I would suggest that once you have it, probably, that, like time frame, it's reasonable, and once you solve it, so you need to wait 6 months, or you need to wait 45 days to check that it's nothing, bad coming. And the other thing is that the treatment, for how long? 1 month, 2 months, 3 months. It's also related with the surveillance, no? And as with Lorenz, that we were trying just to make the consensus, I don't know, like once we have it and the patient was on DAPT or SAP, I think that it's reasonable to switch to DOAC, and the patient is a high risk of bleeding, maybe half those DOAC. But if you have a DRT, that it's kind of uncommon, but if you have a DRT with DOAC or OAC, so what we should do? So I think that this is something that we will try to find out in the DRT registry of the ELAACC. So we are already collecting patients. So I mean, is there anybody interested in participating on that? It's just collecting, patients with DRT. It's not so difficult because we only need those patients, but those patients are going to be studied in a high level, of I would say like depth, no? And we're going to get a lot of information from them, so to try to understand and what we're doing, how they manage, how they behave. So that was it. Thank you.
Thank you, Xavier. I think we opened the discussion right away. I mean, you put up certain questions on treatment and follow-up imaging. I would like to mention first or comment on your last slide, because I think this is lucky enough something very infrequent, 1 to 2%, which makes any research extremely complicated due to lack of power. And there is only one way, and this is unify forces, not only to study predictors, but also treatment. I mean, you suggested low-dose DOAC, which is courageous, I would say, to look at. I understand if the bleeding risk is excessive, like patient with previous plain bleeding, the rationale is there. But if the bleeding risk might be intermediate, small GI bleeding or whatsoever, are we really ready to do that? That's a question.
But there are a lot of questions because you want just to fix or solve that DRT very fast. So maybe there is a higher risk of, embolization, or you want just to be progressively, I don't know, maybe it makes more sense, just to go slowly and be more gentle. And on the other hand, you have a patient that it's a bleeder. So, of course, I don't know, but maybe it makes sense. So the only thing that I can tell you that in our experience, apixaban half dose has always worked with DRT patients. It's true that we don't have patients, with DRTs under, of course, anticoagulation, but for the patients that were on antiplatelet agents, DAPT or SAPT, it works.
And what's your consideration on the reversal if you have patients with excessive bleeding risk? Like if somebody presents with recurrent intracranial hemorrhage, no, just the balancing between, for example, low molecular weight heparin.
Well,
is that an option you also?
Yeah, sure, but at the end, for that maybe, the most scary one is the intracranial hemorrhage. So apixaban half dose, especially for intracranial hemorrhage, it's a safe, drug, because probably, the rate of intracranial bleeding, it's very low. But I would also consider low weight molecular heparin, even half dose, instead of, just anticoagulation, prophylactic.
Yeah, Xavier, two questions, because as I understood, your protocol is that you gave apixaban, then you stopped, and you always do a TE 3 months after switching to single antiplatelet. 3 months or?
There's no protocol.
Yeah, but I'm asking about your protocol.
No, for example, I consider that maybe, the first cases that I show that are not really scary, so I treat them, I assume that it's going to be effective, so there's no need to repeat it in 1 month, maybe. But for the big one, so maybe I, just shorten the follow-up period, yeah.
Yeah, and another question, because, and what is your protocol? It's outside vet, but if you have a thrombus in the appendage before the LA, before the device, because my experience is that I have never seen a case in which I dissolve the thrombus with DOACs, only with warfarin or low molecular weight heparin.
Yeah,
so we are doing, after, if we have a thrombus on the device, we are using the protocol with low molecular weight heparin because in our hand it works. So I am wondering what's the consensus in the room. Are most of the people doing like you, so with low dose of apixaban?
No, but I'm, in this case, I'm changing. So if it's a patient without a risk, I just close the appendage and I keep full dose. Of heparin. It's like a Laos 4, no? That needs, in addition to on top of the anticoagulant, needs like the closure.
Yeah.
But of course, if that patient with thrombus also has bleeding risk, so probably I will try half dose.
Okay.
Yeah.
Mm-hmm.
So to me, there is a common thing that we saw in all these patients, and is that they all had a spontaneous echocontrast that itself is not the cause of thrombus, but is a phenomenon of some endothelial dysfunction, of arteriopathy that we are learning to know more and more lately. And so itself is a condition that we are not going to treat, like the hypercoagulability is a condition that we are not going to treat with appendage closure, and that's why we see that these patients have recurrent DRTs, and that's the reason why probably anticoagulation is the best strategy for these patients. We have, when we started half-dose NOAC in in parallel probably with your studies, we started in patients who had all spontaneous echocontrasts, and we were keeping patients on half dose in combination with appendage closure for long term. So these patients have been on half dose and are still on half dose for now. We started in 2017, so these patients have appendage closure and half dose, and we had very, very low rate of recurrent bleeding, intracranial recurrent bleeding, well, basically comparable to a patient who is on off anticoagulation. So I think here the problem is that there is an underlying situation that is predisposing to DRT, and probably those are the patients where appendage closure is not enough. You need a combination of anticoagulation. Maybe in the future factor 11 might be a combination, because we know that with the dosage that we have, it is not as efficient in preventing stroke, but can can reduce bleedings. So maybe that dose that we have now can be efficient in reducing the risk of DRTs. And then the stroke part is not that important once we close the appendage.
Xavier, I have a question for you. I think we all agree that when we find the DRT, we have to introduce anticoagulants. Half dose or full dose, maybe, depending on patient's profile and bleeding risk, potentially. What is to be discussed, and maybe for consensus, is how long? And you said sometimes, and you showed us some patients with recurrent DRT. Do you think that the duration of treatment is depending on the number? Is it, I would say, cumulative, the risk factors for DRT, patients-related risk factors, procedure-related risk factors, maybe device-related risk factors? Should we rely on that? Maybe imagine that if you have only few factors, that was like just an accident early after the procedure, or maybe this patient, because he has this, the device is like this, the patient is like this. This one we should convene or think that he would benefit from long-term anticoagulants.
Yeah, well, at the end, of course, it depends on the bleeding risk, and if the patient bleeds again, so you will be forced to make a change. But after just doing the presentation, what I'm convinced is that that's something uncommon. But in these patients, we need to get more information. So if we are doing TE, maybe in all these patients, so we need a CT. If we're doing a CT, maybe in all these patients, we need a TE, because to check echo contrast, to check if there is a mitral stenosis, I don't know, like factors that maybe we don't detect. We probably need to check for like a thrombophilia. Maybe it's a patient with, like an unknown factor that we can treat, like just with a potential target. So I think that if we need to get to a consensus, I think that the most important thing would be just to try, in those uncommon patients, try to get more information, functional information, like clinical information, biological information, more information.
And you would say, which is probably also important for a consensus, that there should be 2 imaging time points. One during therapy to see whether it is efficacious, and one after de-escalating the therapy because we have a recurrency rate of 30% to prove that in the absence of anticoagulation, the thrombus does not come back.
Sure, and I don't know
is that something which...
or 1 or 2, because maybe, like just you check it after 6 months and you need another one. Maybe you need 2, I don't know.
I think, no, definitely you need to, when you de-escalate, you need to do an imaging, of course, because we have seen the rate of recurrence.
One?
If after 1 it's resolved, at least 1, but I mean that depends on the availability of the patient and so on. But you can do a second one.
Or it's what Lorenz says, like maybe. So if we're suggesting to get more information, maybe if there are a lot of risk factors, so maybe.
But if you, for example, if you have a very deep implantation, a lot of spontaneous contrast, and after the first treatment you see that it has resolved, okay, maybe that kind of patient could benefit from another one. So yeah.
Yeah, we need to go on. Yeah, so we need to move to the next talk. That it's Lorenz, talking about leak management, that it's again, like something super controversial. Yeah.
Yes, so I had to adapt a bit the talk, because of course if you decide on whether the treatment makes sense, you have to have in mind the frequency of the phenomenon, because you can't treat something which occurs in 50%. I mean, then we would need to be forced to stop LA occlusion. And of course, there should be the question is about the clinical impact, and then the third question is whether to apply medical or percutaneous treatment. So the questions are leaks by TEE and CT equal? Which leak type is clinically relevant? Which leak size is clinically relevant? Causation versus correlation is an important consideration here. We need to know and understand the natural history, because if you treat something that disappears spontaneously, it's probably not a good idea. And then the question is, of course, at which time point you need to repeat the imaging, and with which technique, and when should it be treated, and how should it be treated. So just quickly to summarize again the concept of residual LAA patency after LAACC, which is nothing else than passage of blood to the distality of the appendix. We have three potential mechanisms. One is the peri-device leak, the other is the inter-device leak, and the third one, the LAA patency, which we discussed. And regarding the techniques to assess those, with the peri-device leak, we can assess with both, and the other two, of course, reliably only with CT. And I will focus now on the first one, only on the peri-device leak, because this is currently what should be discussed mostly. So the question is TE versus CT. If you do follow-up with TE or CT, what is the difference? From several trials, like Swiss Apero, I mean, on the slide from Casper, there were even more trials mentioned, but there's really a consistent picture that you will find more peri-device leaks by CT. That's a fact. Second, the correlation between TE and CT is not very good, and mainly, as by the group of Casper has been shown, there is a systematic bias of about 2 millimeter in terms of oversizing with cardiac CT. That needs to be taken into consideration. So what is the current consensus statement regarding leaks? Published in 2020. It is saying that small residual shunts with a jet diameter of less than 5 millimeter are deemed irrelevant and may close spontaneously with time. They do not warrant further drug or device intervention. First statement. Second statement, if the leak is larger than 5 millimeter, it's up to the operator to decide. The question is, how and should we potentially modify these two statements? Now, in the meantime, there is one, it has already been shown, but I would like to dive a bit deeper into that study here, because it provides robust data on the association between the presence of TEE and CT-based leak with thromboembolic events. What did they look at? 37 studies with TE only, follow-up with TE only, 5 studies with CT only, and 6 studies with TEE and CT. What was the magnitude of the problem? The magnitude of the problem is shown here. By TEE, any PDL was present in 27%, a PDL more than 1 millimeter in 15%, in 10% more than 3 millimeter. Of course, the option was not included. The option shows 3%, so device improvement. But still, in this meta-analysis, 10% more than 3 millimeter and 1% more than 5 millimeter. Again, recall TEE-based peri-device leak. So that's the magnitude of the problem we are dealing with, which we have to keep in mind. Now, what is the degree of association with thromboembolic events? If you have any leak of any size, it is a 2 times risk increase, odds ratio 1.8. If you have a leak size by TEE, and that's the data we have, of course we can discuss about the importance of TE-related PDL width, but that's what we have. Between 1 and 3 millimeter, the odds ratio is the same, 2. If the leak is between 3 and 5 millimeter, there is a considerable increase in the risk for thromboembolic events. The odds ratio is 4. And I think that's not, well, that's clinically relevant. And if we go and look at PDLs more than 5 millimeter, it's also 4, a little higher, 4.5. If we, however, look at any patency by CT, there is absolutely no correlation or association with thromboembolic events. If we look at the scarce data available for CT-based PDL, there is also no association with thromboembolic events. But of course, there is much less data as compared to TEE. So regarding clinical relevance, we can say that any TE-detected PDL is associated with thromboembolic events, 2 times risk increase if the size is between 0 and 3 millimeter, and 4 times risk increase if it's above 3 millimeter. CT-detected PDL leaks do not associate, maybe due to systematic overestimation of leaks. Maybe it's just a function of the sample size, we don't know, because there's a huge difference in terms of patient numbers studied. And there's also a question of correlation, of course, between TE-PDL and CT-PDL. That requires further study. Then the next question, which really is challenging, that's not answered. Is it causation or is it correlation? In favor of causation is, of course, there is a mechanistic rationale. We believe that platelets are formed, that is, there is thrombus that may embolize, and we know that there are modifiable risk factors that are not related to the degree of atrial disease. For example, an off-axis implant can happen in any patient profile, depending on the LAA anatomy. However, there are important factors speaking for only correlation and not causation. Look at this comparison of patient-related risk factors in patients with no leak blue, small leak orange, and large leak. There is a consistent gradient getting higher in patients with larger leaks. For example, patients with larger leaks did have more previous stroke. They have more frequently cardiomyopathy. They have more frequently permanent AFib. They have more frequently atrial flutter, and their LAA orifice is larger, indicating that there is more disease present, and that's supporting the correlation hypothesis behind. Regarding the treatment, of course, the mechanism is an important consideration, and from the Amulet ID, we know that the key mechanisms are off-axis and a missed proximal lobe. Now, the best therapy for PDLs, of course, is to avoid them at the beginning. And we have various aspects that need to be considered here. The first, of course, and that was largely discussed during this meeting, is planning. Planning with TE and CT, maybe include this computer-based simulation to really select the best landing zone. Second, we need to select the devices according to anatomy. We have different devices, and the anatomy should determine which device we use. And the more devices we get, the more selective we can be. Then, of course, we need to aim for a perfectly coaxial implantation, and here the transeptal puncture is extremely important, but also the consideration of steerable sheets. There are some, but I think industry must be improving in that regard. We should avoid undersizing and, of course, have high-quality imaging. And the call for industry, the sealing, of course, must be improved. I mean, look at the evolution of TAVR prosthesis. The peri-device leak came down dramatically, and I do not observe this in this degree with LA devices. Of course, it's a much larger market, I understand that, but nevertheless, this must be addressed. And then we have non-modifiable risk factors like the ones I mentioned that speak a bit more for correlation. Now, of course, now the question is which ones to treat. Of course, we don't want to treat something that disappears spontaneously. That would be a bad idea. Do we have evidence for spontaneous resorption of PDLs? Yes, we do have. Between 10 and 40%, depending on the studies you look at, these leaks, peri-device leaks, as assessed by TEE, disappear. And this is quite consistent, a study from Aarhus that shows the same. You see here -3 degrees in 10%, -2 degrees in 20% in an amulet cohort. The size is also decreasing significantly, mainly at the left side in smaller leaks as compared to larger leaks. And the same we have observed in the Swiss APRO trial by CT, where we have a 10% complete resorption of side cap leaks. And it is possible to assess predictors for resorption, but this is an open research field and clearly needs more evaluation in the future. Now, when should it be treated? I mean, if it's clinically relevant and proven not to resolve, I think that's that point in time where you need to potentially do something if you believe in causation. And then the question is DOAC reintroduction futile because of excessive bleeding risk? If no, should we put the patients on regular or low-dose DOAC? That's an open question. And if closure is technically feasible and the mechanism supports that, you should opt for that. The question, of course, is the experience available at the site, and is the patient also willing to undergo an additional procedure? These are questions that may come up. I want to introduce my next speaker by just giving an overview on the interventional techniques that are used. That's, to my knowledge, the data available currently. You see there is a heterogeneity in tools that are being used: coils, plugs, RF ablation, or even second LA devices. Some sites use several of these. Some are focused on one technique. And if you do something for which there is no RCT proof, which is the case here, you need to know the potential harm that you may cause, and that's shown here. The MACE rate of this intervention per se ranges between 1% and 6%. That's the first aspect. The second aspect is you need to know about the efficacy of the treatment that is not proven in a causal manner to be efficacious, and the efficacy is about 70 to 90%. So if you do it, it works quite frequently, but not always. That's also an important consideration. So to conclude, are leaks by T and CT equal? No, currently only T-based PDL are associated with thromboembolic events. Which leak types is clinically relevant? According to the studies we have shown, any T-PDL is moderately associated, and if it's larger than 3 millimeter, highly associated. We can't change that. That's the data, what it tells us. Causation versus correlation, likely causation, but there is an association with a higher degree of atrial disease, which we have to consider. How is the natural history? 10 to 40% resolve. That needs to be taken into account when making treatment decision. At which time point? Of course, most imaging is repeated at 1 year in most of the studies, T-based, and the role of CT still is unclear, mainly if it's not serially performed. And when should it be treated? That's, of course, a discussion, but based on the discussion on the significant association with outcomes, you could argue more than 3 millimeter with clear flow. DOAC if possible, otherwise consider percutaneous treatment if the experience is available and it's deemed technically feasible. That would be my conclusion for my part. Thank you very much, and now we would like to start the discussion.
So I don't know if it's going to be better just to listen to him and then we make a full discussion, no? Having the two sides, you know, the medical and the percutaneous.
So good afternoon, ladies and gentlemen, and thank you to the program committee for this kind invitation. So we'll talk about how to close percutaneously leaks. So first of all, we know that left lateral appendage exhibits a high inter-individual variability in size, shape, and course. And so incomplete occlusion and leaks are the results of a mismatch, generally the results of a mismatch between the irregular morphology of the appendage and the circular shape of the occlusion device. However, the most important point to keep in mind when we plan a closure of the leak is that leaks are three-dimensional structures. So it's very limiting to think about a leak of a diameter, so 3 millimeter, 4 millimeter, 5 millimeters, although it's the most practical way to consider, to classify leaks. So three-dimensional structures, so we have a length, we have a diameter, we have a correlation between the device and the anatomy of the left lateral appendage. And these are all the things that we need to keep in mind when we want to proceed and occlude a leak. So this classification of like eccentric leak, concentric leak, stump, and uncovered lobes is obsolete. It's like a very simplistic way to classify leaks, but it's not a way to understand the importance of the leak and what should we do for these leaks. This is a very elegant study that tried to summarize the different mechanisms behind the leak formation and also the correlation between the device type and leak formation. And so to date there are 4 different ways to different ways to occlude leaks. And so we can use a second appendage closure device, we can use embolization coils, plugs and occluders, or radiofrequency ablation. And I will try to correlate each technique with the different classification of leaks here, so first of all, let's start from second LAO device. And so the best way to decide for a second occlusion device is that you have like a structure that can be occluded by a device. So in general, if you have a large uncovered lobe, this is like a good combination. Here, rather than a large uncovered lobe, we have a covered lobe with an uncovered appendage. So the device was, this is a patient that was referred to Dr. Orton a few years ago. The device was selectively deployed in a lobe of the appendage, and the appendage is completely uncovered. So what we did here was opting for a second device that was deployed inside the main body of the appendage, and then this is the final results on fluoro and on intracardiac echo. Second approach is embolization coils. So like embolization coils find their best way, in my opinion, a field of use for edge leaks, uncovered proximal tissue, or like leaks between disc and lobe, leaks in the distal part of the LAA. There are different coils that we can use for a leak closure. There are fiber-coated coils and hydrogel polymer-coated coils. So in our early experience, we use mainly fiber-coated coils, and then we switch we switch to a hydrogel polymer-coated because the thrombosis that they create is a little slower, and it was giving us a better manipulation and better chances to completely occlude the appendage with the coils. But the main concept of the coils is that you don't occlude a leak, but you occlude the full volume that is behind the leak. So first of all, you need to have a boundary, like a physical boundary that keeps the coil in position. So we never consider using coils if you have like an uncovered lobe or something like this, because there is a very high risk of embolization. So you need to have a physical boundary, and then so the process is filling the full gap of and then until you reach the area behind this physical boundary where coils need to be kept. And this is like a little bit the stages that you follow. So contrast injections and then several coils. Here we injected a contrast, and we have another proximal pouch that was completed, and then we have complete sealing of the appendage. And this can be used for different devices, from also amulet or post-Lariat leaks. So, as I said, the key concept behind the use of coil is that you need to be safe in terms of risk of coil embolization. So the same concept that is used for aneurysm, you need to have a narrow neck, you need to have a volume behind the narrow neck, and that's why the decision between the use of coil or the use of vascular plugs or septal occluder is also the space that you have available and that you have to fill. Other devices, so plugs and occluders, uncover lobes, uncover proximal LAA tissue. And here this is an example of like a leak, a 7 millimeter leaks post lariat that we closed with a cardioform septal occluder. The last approach is radiofrequency ablation that generally we used for edge leaks, leaks between disc and lobe, leaks into the distal part of the LAA. And this is the study that we published in 2021. The idea behind the use of radiofrequency is like in Austin, there is one of the main approaches for arrhythmia recurrence control is for ablation is isolating the left atrial appendage. So we notice that patients, but we always do a stage approach. So we isolate the appendage with RF, and then we wait 6 months to occlude the appendage. And so we had in these patients a peak of appendages with very stenotic ostium. So this is a case of a patient with a 9 millimeter ostium, and we occluded with a Watchman flex. So we quantified these changes in ostium size, and this is what happens. So in red, you see the mean maximum diameter before ablating the ostium of the appendage, and this is the TE, the size of the ostium after 6 months before occluding the appendage. So as you can see here, there is a shrinkage, so there is a fibrotic retraction of the appendage, there is stenosis of the appendage. And so the idea behind the use of RF is that if we can create a shrinkage of the area where the leak is and somehow a stenosis, we can use this in our favor to occlude leaks. And so this is a 3D ice, and you can see here an edge leak. So what we did, you need to have a good support from, so generally it's like a 2-operator procedure with an operator who takes care of imaging, guides you during ablation. Clearly this is like the optimum choice in case you also need to re-ablate the patient. So generally those are patients we were occluding, they needed a redo procedure, and we were ablating the arrhythmia, and also if there was a residual leak, treating the residual leak. So you can see here that there is the ablation catheter. The most important part is that you need to target the tissue. There is no risk when the ablation catheter is in contact with the device, because as soon as the tip of the catheter is in contact with the nitinol cage, the nitinol is a low impedance material, and so the generator immediately detects the reduction in impedance and the discontinued radiofrequency. So, but one risk of the approach is that the catheter needs to be on the atrial side of the leak, and because if you get inside the neck of the leak, then the irrigation of the catheter is reduced, and there is a high risk of overheating the tissue and having steam pop. So everything needs to be done under a continuous imaging guidance, and with the catheter on the atrial side of the leak. And here is a merge of the like a CT merge on a Carto, and as you can see here, this is so you need to go all around the whole length of the leak, because if with just one point you are not going to achieve this shrinkage, this stenosis of the appendage. So you need to cover a wide area of the leak in order to have this retraction. There are two effects here when you ablate. First of all, acutely you have edema. So here, for example, we know that there is no residual flow, because immediately after ablation, you start seeing this stasis, and so there is stagnation of blood, and immediately you have thrombus formation in the appendage. This is not a moment to stop ablation. You need to cover the full area, and also because edema resolves, but shrinkage occurs in the following weeks, and so that's why you need to give a bonus application in the area of leak in order to have this fibrotic retraction. So one question is, okay, acutely we have 90% success, 80% success, but to try to answer Lorenz's question, Is there a correlation? There is a causal effect. What happens is what we see in terms of clinical events in patients with leak. If we treat the leak, what happens in the long term after treating the leak? And so in order to answer this question, we put together a large multi-center experience with 7 international centers, and we were able to collect 289 patients who underwent leak closure. And so what we observed before is that in the time between all patients, the mean follow-up between appendage closure and leak closure was approximately 12 months. And during these 12 months, we had a yearly rate of thromboembolic events that was basically similar to the one expected based on the Charles-Vasco population. For sure, this is like a selected population because patients were sent to leak closure because they had, and the majority of them had a clinical event. So, but still, it's interesting to notice that the rate of thromboembolic events in this population is very high. So this is the procedure. 73% had a moderate leak, 26% a severe leak, 85 minutes of procedural duration, and this is what we had. So major complication, 3.5%, 1 death, 2 stroke, 2 TIA, 1 air embolism, and then 3 cardiac tamponade. So then patients were followed for, on average, 26 months after. And these are the outcomes after leak closure. So this is the expected rate of the thromboembolic events, and this is what happened after leak closure. So there is a 72% reduction in thromboembolic events after leak closure. How it compares comparing to the time before leak closure, between appendage closure and leak closure. So this is the outcome between appendage closure and leak closure, and this is the outcome after leak closure. The same for thromboembolic events, and this is for DRT. We also wanted to compare this population after leak closure with a matched population who had successful appendage closure at the time of the index procedure. And as you can see here, the results are very similar. So basically, once we close the leak, we have the same outcomes of a matched population with similar risk factors who had successful appendage closure. So in conclusion, it's very important. The key point is that we need to thoroughly assess for any presence of leak at the time of device deployment. This is the most important thing because the procedure, as we see, is not easy and there is a high risk of complication. So at the time of appendage closure, we really need to aim for perfection. So if we are not happy with the result, it's better recapturing and trying again rather than some operators might think, okay, like let's see how it goes. If it's not convincing at the beginning, it's not gonna go well. So let's aim for perfection, and then in high-risk patients with incomplete appendage closure, consider closure if there is a clear residual flow irrespective of leak size. We saw in this series that 75% had a moderate leak. Also, a poorly planned leak closure procedure can cause more harm than benefit, 3.5% risk of major complication. And if you decide to move forward for a leak closure, ask for guidance support from your team, EPs, interventionals, imaging, and an experienced operator. Thank you for your attention.
Okay, great talk. Impressive results. And I don't know if there is any comment, yeah.
Fantastic presentations for giving from all of you. I totally agree the best way to treat leaks is to primarily avoid them. And your point, Domenico, with looking very closely when we do the procedure that we don't leave a device with a leak there. I think that's a very important message, but it's not that easy because the way we diagnose leak 45 days or 3 months after the procedure is from TE at least that we look for color flow jets. And I suspect that this is also done in many centers at the time of the procedure, but the situation is different because when you acutely put in a device, there will be flow also into the device membrane, and you will not get those high velocity color jets that you see again after 45 or 3 months. So if you look at all the studies, there's a much higher sealing rate at the procedural time compared to at the follow-up. So if you want to diagnose a leak at time of the procedure, you have to be open to look for gaps, look for additional lobes, and not just look for color jets. And I think it's a difficult task actually to be completely confident that here we have a situation where we have complete sealing. It's helpful with our control angio, but we really also have to be careful with whatever modality that we use to be sure that we have sealing or leak.
Yeah, Adele. Yeah, Adele.
Something that congratulations for the talk. But something that puzzled me. Okay, if you have a patient with a leak, okay, but not the one that you have shown. This is a not closed appendage, but the patient has no symptom, no stroke. So it's primary prevention. So you will close the leak because there's a leak and you want to prevent something. Okay, so that's a question. And then you have the patient that has a known leak and develop a stroke, and you don't know if it's causal or is it something else. So to what extent you search for something else before going to close the leak, and what will be your cutoff then to close the leak? Any leak, or then the patient does a stroke, has a leak, what do you do?
So, I mean, this is so first of all, I don't think there is a size. I think there is a combination of a diameter or we need a very good assessment of the anatomy of the leak itself, and so is a. For patients with stroke, I think, based on the relatively limited data that we have, it seems that if we treat if the patient has a leak and has a stroke, there is a likelihood that the stroke there is a correlation with that, and that if we treat the leak, we have basically we are realign with the risk of the population that we would see if we had closed efficiently the appendage. In primary prevention, I think is much harder. I think the majority of the patients that we have in the series are patients who were put back on, who were on primary prevention closure, were put back, either had like serious leaks or like a proximal pouch that was like an evident leak. Otherwise, those with a 2-3 millimeter leak, edge leak, or were patients who were maybe put back on anticoagulation and had a bleeding, and so we really had the need to stop anticoagulation and do something else for the patient. So, but it's hard. It's like always a combination of the risk of bleeding, if there is but I feel not confident, but it seems there is a quite definite trend that if you have a leak and you have a stroke, the likelihood that there is the correlation is there. So maybe not 100%, but I believe that the leak needs to be treated.
But it's true that it took a few years to demonstrate the correlation between DRT and strokes. So, I mean, if there is a relation, it means that there is probably a DRT in between, no? I mean, so what's the other mechanism? It's turbulence, then a thrombus, and then goes up. So what I cannot understand is why, we haven't been able to correlate the presence of DRT with the presence of leak. And that's, what actually, it's driving me, and I don't know, like, how many of you, like, always just put anticoagulation if you see a leak in the disc of more than 3 millimeters? So can you raise your hands? So how many, always? Nobody? So, I mean, we're just not following what it's recommended. So I think that, I don't know.
Oh, it's an interesting question. I mean, if you have stroke patients with AFib, you occasionally detect a thrombus in the LA. And who has ever seen a thrombus in the direct context of a PDL? I have never seen that, but has anyone ever seen that?
Yeah, I think
But the question, of course, you can say with it embolized, but still.
I think so. We have some data from surgical experience. I think was the Cleveland Clinic that published in the 90s between ligation and risk of a stroke. And the correlation that they found is that the smaller the leak, the higher the risk of stroke. That is somehow a contradiction, but to me, it somehow makes also sense, because I think there is the turbulence. The higher the smaller the leak, the higher the turbulence. But at the same time, I think a very important information that we can get when we image the appendage is also the amount of thrombus that is forming beyond the leak. And that's also like a secondary information on how much flow we have beyond the leak. So a leak of 3 millimeter with an appendage that is completely unthrombosed suggests me that there is a big flow. And there is a big flow plus a turbulence, plus sometimes like a pouch that is right behind the leak is a very high risk patient, in my opinion, because generally the pouch is very irregular, and so the risk of stagnation, the risk of thrombus formation, and I don't expect to see a thrombus forming inside the pouch, but I see some small emboli forming and washing out through the appendage. So I think the combination of these is a...
Yeah, Domenico, a practical question. So in your practice, if you have a patient with a leak who had a stroke, it's always indication for closure? Yeah. Always or not?
No.
Yeah, okay. And if you have a patient without a stroke, but with a leak of 3, let's say, we are discussing, we are measuring the area, which patient you are sending for, or you are closing, and which patient you treat just with drugs?
No, I think so. The first step is, I think it's important to have like a follow-up, imaging follow-up of the leak. So if I see a leak at the beginning, I don't think about occluding a leak at all at the beginning. So unless it's like some dramatic case of, as we see, like a large leak and completely uncovered lobe. So I wait at least 6 months and do imaging to see the evolution of the leak and also the evolution of the thrombus behind the device, and then decide, and that's basically the workflow that we were following in Austin. So like 2 imaging at least 6 months of follow-up, and then move forward in case the anatomy, so as I was saying before, leak size, presence of pouches, complete absence of thrombosis inside the appendage, then we consider.
Yeah, and if you in 2 imaging, one and the second one after 6 months, you still have a pouch and there is a leak, how many % of these patients you send for closure? 10%, 100%?
I would say around 10 to 15%.
Okay.
Just a consideration. I had some cases of thrombus. One, I remember in the leak, and but 2 or 3 I can remember well, but attached to the pin of the device. One particular case, the thrombus was also in the septum inside the puncture site. So we have much more to understand, in my opinion, in these cases. But I have a question. What about the therapy after implantation? Because now we have imported the APT from the stent, the coronary stent. We have no data about that. There are current trials ongoing. But why not give directly apixaban LAF doses for some months, obviously? What's your opinion on that? And regarding the leak treatment, I don't know how many of you have treated leak with coils, or so it's difficult. I'm not the courage to put a coil inside the leak.
That's actually a good question. We can make a vote. So who, given the scenario that you have at your 1 to 3 month imaging, a PDL detected by TEE in a patient that has a moderate bleeding risk, what would you do as a next step? Would you, let's say, in a PDL larger than 3 millimeter, because obviously this is, and nobody can say that's not true, is associated with a 4 times risk increase of thromboembolic events. So what would be your next step? Is it consideration of reinstallation of ELAACC if there is no excessive bleeding risk, option 1, or option 2, you would consider, if technically feasible and the experience available, a mechanical percutaneous closure, or C, would you wait and observe and do nothing in between? So who would reinstall any kind of oral anticoagulation DOAC in a PDL larger than 3?
The patient is not hemorrhagic risk so high.
No excessive bleeding risk.
I think it's a good option. Alpha doses of.
So hands up, who would do that? PDL by T more than 3 millimeter. Who would reinstall oral anticoagulation, half dose or full dose? So maybe 1/3. Who would just observe? Option C. Most would observe. And who would consider it for percutaneous closure? And what are your
I have the microphones.
What are your considerations here, Jens Erik? Now you need to provide some arguments to convince us.
Yeah, no, I can try to clarify my thinking. We do follow up with CT. If we on CT see complete LAA patency, we know there is an underlying problem. Then we try to understand the mechanism, and also it's a good thing also to do a little bit of quantification. But I will say that in at least 80% of the cases we have with leak, it's a matter of off-axis device position. And if you look at the Watchman Flex device, if you have this situation with a tilt of the device, or probably it was put in off-axis, you have a prominence of the inferior posterior part of the device, and flow from the left atrium can go underneath the fabric membrane. And it can go directly with a large flow into the bottom of the LAA. For me, that is a situation where I have, you could call it an implantation failure. I tried to close this patient's appendage, but I didn't succeed. I ended up with an off-axis position. And there can be several reasons for that. Of course, thinking back upon the ELAACC classification, there can be a pronounced, for example, anterior axis. And I have only a double curve sheet available. In the elderly sheets, we also had an anterior curve. I might have mistaken and taken the double curve, but anyway, I didn't succeed in bringing the device up so it was perpendicular to the axis of the appendage. So I consider this in some way my own, it's an implantation failure. You could also argue that this is lack of adequate tools, because I'm a strong believer that we can improve LAA sealing by having a steerable sheath and making sure that we have on-axis device implants. That will be the first step. And then second, I will consider to try to correct this failure that I actually made for this patient. And we can do that, and this is also part of your experience, Domenico. I know you are using coils, putting them into the intra-device space of the flex device. It also works very well by putting the amplats of vascular plug 2 with the distal disc, the middle waist, into the intra-device space, and on the outside you have the proximal disc of this AVP2, and in that way you cover this, we call it subfabric leak or skirt leak. So that is that is one situation where I would go for closure. The second situation is if I have overlooked a lobe, if I have a missed lobe, if I directly have a flow into a cavity with slow flow, trabeculations, etc. And sometimes we have complex anatomy where we, at the intraprocedural time that we have available, acknowledge, okay, I cannot close this inferior posterior lobe, but I can close 90% of the appendage, and afterwards I can take the patient back after 3 months and put in a vascular block and then do my job, finalize my job. So for me, it's a matter of very much looking into the underlying mechanism for the leak. And also, as you said, if you have a very strong flow that really can wash material out of the ELAACC. I haven't closed the ELAACC for those patients that come with an off-axis. It's my fault, or it's the tool. We have just to be better. We have to require a steerable relevant sheet for putting this device in, and we have to make our considerations about, is this a difficult axis, or what tools do I need in order to land the device? Okay.
No, what I completely agree, and I think that an uncovered leak, an uncovered lobe, cannot be called a leak. It's an uncovered lobe, and it's a different situation. It's true that sometimes it might be confusing, but I think that it's a different situation. Sorry.
So what's the frequency then of?
It is quite rare that we have this situation, but we have had I think 10 cases with this off-axis position, and if you put it in just slightly off-axis, it can also with time tilt even more. So it can also be a matter of...
I understand that point, but going back to epidemiology of leaks, I mean, we know that we have more than 3 millimeter leaks that clearly associate with thromboembolic events in 10%. And we have more than 5 millimeter leaks in 1% currently, according to what we know. So, and the question is, for everyone, what to do with those leaks. So the first question really is, when is it significant to do anything? And then what to do? But obviously, if you say 10 cases, you don't do that in 10%.
Oh, but Lorenz, actually, how will this type of leak, which I really believe is the most frequent type of leak with the Flex device and probably also other devices, how will this leak be described on TE? It will probably not come out like a 5 millimeter leak. It might even not come out with a 3 millimeter leak. It will come out if you look what's going on with CT, because there you can really evaluate also the device position, or at least you need a very, very good three-dimensional TE examination. Then you can also acknowledge that. And that's also my hope, that we can agree that we have to come away from talking about 3 and 5 millimeter, because it's simply not correlating to what is the anatomy and what is the underlying explanation.
No, but just to comment that the problem with CT, the more you search, the more you find disturbing things for an operator that you are not happy with yourself because you have not closed the appendage completely. So that drives you to do a lot of things. But look just at the rate of stroke, the annual rate of stroke. All the studies, it's 1.5, 0.9, 1.7, and you put that in perspective with the rate of even TE. I mean, what will be the correlation? You have a low event rate, you have a low rate of leaks. So if you put all together, I mean, the leak is maybe not so important. I mean, you will close a very few leaks. I think, Domenico, you work in the US. All these cases were referred to you, I know, from many surrounding centers. I know that. But imagine a center, me, I've never done that. So I would call you, for example, to do it. But because now you're in Belgium. But I mean, who is going to do that in the room? I mean, it's another procedure. Okay, Jens Erik is very experienced. But who is going to do that? I mean, and what will be the reason to do it?
I just want to give my insight. I think the debate is really great, and as you mentioned, first, what is reassuring is that the rate of ischemic events is quite low, even in populations with leaks. Second, we don't know, and Jens Erik said, we don't know really how to quantify, and even the I would say the risk of ischemic events depending on or related to the mechanism of the leak. This is something that we don't really know. Third, you mentioned anticoagulants, but why anticoagulants would improve the risk of ischemic events in these patients? Because we don't close the leak with anticoagulants. So you just, I would say, postpone the risk of ischemic events to, I would say, later on when you stop anticoagulants one day, if you stop one day. And then, Domenico, what you show is really great, but as Adele said, we have very low experience and we rely on 2, 3, 5 centers with very low experience, so we don't know which patients may benefit from this. And we don't know, I would say, what is the best technique for what anatomy, what mechanism. All this we have to improve, but we don't know.
So, but what would be then your practical recommendation? I'm sorry to come back always to the same, but what we find is we do an echo or we do a CT at 1 to 3 months, and we find a leak. So the question is what to do. You say now no DOAC because it would just prolong the problem or defer the problem. But there is also spontaneous resolution, 10 to 40%. So there would be a rationale to reinstall it until it's occluded potentially. But the question is what to do. And if you say, Jens Erik, I want to know the mechanism, but which one then? What would be your concrete proposal on which one to target primarily? Which leaks primarily you would target by percutaneous treatment? I think we should come up with because that's what we need to respond to the operators, no?
Yeah, but the most important thing is what happens in the middle between the leak and the clinical thromboembolic event. So if we believe that that's a thrombus in the meantime, and that it's generating, so then we are on the DRT sphere, so all the risk associated with the DRT, meaning echo contrast, permanent AF, I don't know, like just whatever, thrombophilic situation, cancer, so these are gonna be added factors for risk. And then if you have a leak and you have all these factors, then probably, it's worth it just to give anticoagulation, just to treat it. But we need to know what's happening in between. And we don't know because nobody has related DRTs or thrombus with leaks, and I don't know. So,
but yeah, it's a nice discussion, of course. But if you indeed go back to real life, yes, I've done 5 closures in my life, post with leaks, and you have to go back to practicality. There's no data about relation with stroke or no stroke or this or that. We don't have these data, so we can debate here hours. The only thing you really look for is this technically feasible, yes or no? I mean, that's the only thing. So if I see even a PDL, a leak of 5 millimeter, but it depends where it sits, it's like very proximal or there's nothing to anchor in or anything, then I decide, look, it's not worth, it's technically not feasible, I'm not gonna start doing it. Yeah, but if I see a leak where I think, yeah, this is relatively easy to put a plug in, I can do it, probably, and I don't assess the risk of the procedure very high, I will offer this and present this to the patient. So it goes back actually really to technical feasibility, typically. And all the other discussions related to clinical this, that, yeah, that's more theoretical, I think.
But the alternative, it's a treatment. You can give also treatment. Apart from, closing.
But
I agree very much with what you are saying, Ole, and I want also you to think a little bit about surgical LAA closure. If we as an interventional cardiologist see a failure from surgical closure, we will be extremely happy to invite that patient back into the cath lab and put in a device.
Technically feasible.
Because then we complete the job and it's feasible.
Yeah.
And that's why I also believe that we have to look at the underlying mechanism. And for subfabric leaks, it's easy to finalize the job and make full sealing.
But do you think it's fair to summarize that we actually don't know too much about causality and how to treat, and that's a situation, I mean, where we would need to be supposed to generate evidence, and what would be...
Of course.
And I think it's not so difficult, because you could actually either randomly allocate leak patients with, sorry to say, but with a T leak more than 3 or 5, to reinstallation of oral anticoagulation, or if you have an experienced site, to percutaneous closure. The problem is that the events are relatively rare, and you need a large sample size. And who wants to fund this trial? That's the issue, no? DOAC companies probably not, and maybe the coils are very expensive. But
so first of all,
that would be the step to go to convince people more.
Domenico, can I ask, if you do these cases, you have most experience here probably in the whole room. So you do CT? You have CT up front?
no, we do TE.
No? Really?
So what we do is we keep the patient. So first of all, in all the appendage that we do, we keep the patient on half dose, and we keep the patient at least for a year in half dose. So we do the first TE at 2 to 3 months. We check for leaks. If there is a leak, irrespective of the leak, we keep the patient on half dose. So then the follow up.
Okay, I don't follow that, because I mean, sorry, maybe I don't get it, but like, if there's a leak that you consider to close, for me it's like a relatively large leak. I would maybe consider it only personally if it's more than 5 millimeter, but then I would think that, waiting is not gonna let close the leak, or I'm not gonna initiate that patient on why would I initiate them on
We have data that there
anticoagulation?
is an evolution of the leak. So even
From a 5 millimeter leak?
No, if it's a large leak, then I keep the patient on anticoagulation. And then if the patient bleeds on anticoagulation, but those are like 200, I think from Austin there were in total 150 patients out of several thousands occlusion procedures. And also, as we were saying before, like a lot of patients were referred. Yeah. So this is like a large experience from a center that started looking at those strategies, and probably is 1 out of 1,000 procedures or so. Regarding our strategy, if we have a patient that we implanted, that we have a leak that is borderline, let's say like with a diameter like 3 to 5, we don't have an uncovered lobe, we don't have a proximal pouch, then we keep, irrespective of the presence of leak, the patient on anticoagulate on half dose, but then those are the kind of leaks that we don't treat at all. So I'm not pro leak closure. I'm just, but then if I see, as we discussed before, like a device that has a certain position, if I have an uncovered lobe, if I have a proximal pouch, if I have a patient that had a thromboembolic event, or that on anticoagulation had a significant bleeding and I need to stop anticoagulation even at half dose, then I consider closing that patient. But those are all patients who came and were referred, and like probably like 2/3 of them were dramatic cases where we had clear evidence. I mean, except for the first case that was a clear mistake of the operator, then the other cases you generally see that there is something that is so wrong that you need to do something. I'm not talking about the classic peri-device leak of 3 millimeter. I'm talking about patches. I'm talking about uncovered lobes. Then I consider closing the leak.
Yeah. Okay.
Yeah, I think we have to start from the fact that what Lorenz said, it's an assumption. It's an association, not a causation. Incomplete surgical closure is one thing. Incomplete cover of a proximal lobe is one thing. That's something different than peri-device leak with off-axis. If you have off-axis with peri-device leak, I think Laura said it this morning, it's an assumption that it's clot washing out from the distality. It might as well just be a pouch being created proximally. And if you have a pouch created proximately, the leak is just a symptom of malapposition and not a cause of a stroke. The cause of the stroke would be like a thrombus forming in the proximal pouch, which is then washed out. So then, what is then the effect of closure of percutaneous closure? Also keeping in mind that it's a 3 to 5% risk of quite serious complication. So there's no proven causality of leak, and then you're doing a procedure. also, I'm sorry, with no hard evidence of prognostic impact. So no proof of cause and no proof of prognostic impact. With some complication, I mean, I find it hard to advocate in favor of any closure, then I would say, except for the proximal uncovered lobes and the surgical incomplete closures.
No, you have to answer that question because I have another question.
No, I totally agree with that. I totally agree with that. I think it's like it's an extreme scenario of closing a leak is an extreme scenario that we consider also if there are clinical events correlated to. I think like I disagree a little bit on the fact that it's like a correlation. I think there is like a consistent evidence that patients with leaks have higher risk of thromboembolic events. Then it's not the leak itself that is causing the thromboembolic event. I think that even if we don't see a thrombus, that doesn't mean that frequently we don't see thrombus in the appendage in patients with cryptogenic stroke, and then we find AFib, and we still treat the atrial fibrillation in these patients. And there is a high correlation between then to find atrial fibrillation. So even more, if we have an occlusion device, we have some proximal pouch, and we have a leak, I think it's, even if we don't find the thrombus, it's very like there is a correlation based on the data that we have and CDR registries that there is a higher risk of thromboembolic events.
Maybe a very quick comment before going to Martin's question about the indication. You mentioned ischemic events, but if we may have confusion if we say, what about subclinical ischemic events? Because we all talk about stroke and systemic embolism and all these things, but we also have like chronic microembolism with dementia and all these things that is not acute, that is probably silent for most of us. And then we don't know the relationship between Martin.
I would like to direct or have another question. I think once in a while we all see these tilted devices where initially you were off axis, and Jens Erik already mentioned that, and then in the second look it's even worse. Huh? And I always struggle what we do with that because I can't clearly see a leak, yet from the orientation of the device I assume there is something, probably with CT we see contrast. So you're on the panel now, so you're the experts. What do you do with that? I mean, do we even need to think about getting them out or survey them a year? Or I think we need to find a consensus because we won't be able to avoid it every time until we maybe have steerable sheaths or whatever.
I think like if the device is so tilted that the fabric is not completely covering the appendage, I would consider that appendage not occluded. So would do something either putting back on anticoagulation, also because somehow there is like even more slow flow inside the appendage, so there is a high risk of thrombosis. And then there is also a high risk of washout of the thrombus from the appendage. So either put the patient on anticoagulation or occlusion. Like I think those are like probably the only patients that I would really consider without thinking of for an occlusion. Either a vascular closure, septal closure, because you really go through the fabric, through the nitinol cage, and deploy and close that part. But then if the fabric the device is so off axis that the fabric is not covering, that appendage is not closed, in my opinion.
So to sum up, it is a classical dilemmatic situation. We do have a clear association, and I just want to remind you the association between DRT and stroke is a 6 times risk increase, and here we have obviously a 4 times risk increase. So, and we are hesitant because the treatment we can offer needs a very high experience because it carries a certain risk if you do it not properly. And then on the other hand, we would have the reinstallation of oral anticoagulation, which you don't like, or for obvious reason, because 80% of our patients are at high bleeding risk. So this is a clear dilemmatic situation, and the way out is very challenging and cannot be answered probably today. But at the same time, I think the key is really the key, not the low-hanging fruit, but the key is prevention. And for that, where we really need to improve is steerable sheet. There's nothing really usable to date, and the device per se, which is not sealing enough. I think that's the consensus we minimally can reach. I would say the feeling is that most don't do anything with leaks for the time being. They may consider low-dose DOAC potentially, but not closure. I mean, that's a matter of fact because nobody put his hand
except for what we discussed of a device of axis or like a complete uncovered lobe, then in that case.
There's a comment.
Yes, thank you. I was wondering if we could distinguish situations in function of because we start with the concept is it symptomatic, is there an ischemic thing, but we could say that if there is thrombus in the appendage part of the device, then maybe the risk is quite high in this patient. I wonder if we are able to know if there's thrombus in the leak part instead of the device part. I think maybe it's difficult. So if there is thrombus in this appendage and it's not closed, it's maybe a higher risk situation. And maybe, as said Philippe, if an imaging of a brain shows little ischemic, non-symptomatic strokes, it might be a second situation with high risk to do something more than just survey.
Just recall in the leak group, 30% had a previous stroke, so that will create even more confusion, I guess, if you do imaging and then argue that if you find something,
I think that
risk stratification is a good approach, but I'm not sure whether.
I get your point, but it's not the way we see it. If you have a large leak, if you have a subfabric leak, and you have a big flow inside, you'll never see thrombus in the distal of the appendage because it's washed away all the time. I think it's the same mechanism that Domenico.
But maybe if you have a good flow, then maybe you'll never have thrombus. I mean, we don't know exactly the mechanism, but you see some appendages which are really well flowed before you close them. And if you have a high flow, maybe it's not worse than an open appendage.
I mean, high flow is not the same as a normal flow through the left atrium. It's still a slow flow area, but I have never seen this combination about a large leak and then in the bottom of the ELAA there is thrombus material. I've never seen that.
So to answer the silent lesions, I think those are patients with AFib. Probably all of them have some silent lesion cerebrally. So it would be what we would need is like do a baseline the CT or MRI and then study these patients again. So I think this is not something.
What I really would propose, I mean, looking at your event rate in the cohort that you occluded before occlusion, it's 10%. This is exceedingly high at 1 year. And the sample size you probably would need is not that, it's maybe 400 or 500. And you should just randomly allocate them to closure or not. That would be, and the hospital may be even happy because the coils are very expensive. So if you cut it half, I don't know. But this would be a way out, no?
I think, as I said, this 10% is a kind of biased result because those are patients with a high risk that were selected.
Yeah, of course, but if you can't prove it in the high-risk patients, it will not be valid for the low-risk patients. That's my point.
Because then, but there is also the data that after in 2 years on average follow-up after leak closure, basically we have a very low thromboembolic event rate. So I wouldn't rely much on the 10%, rather on the significant reduction that we had after closing the leak. So those patients are high risk, who have 10% before, but clearly in order to decide to close or not a leak, had also a high event rate. Then after the rate goes very low.
Yeah, exactly, but if this is causal, then you should not see it in the control group without closure.
Yes.
Okay, I think this was a very
inconclusive
session. I didn't dare to say it, but it's what it is. And thank you so much for this active discussion.